Good to see you. As I said before, I am a consultant and trainer here at the Best Center at NEOMED in the CBTP program. That's the Cognitive Behavioral Therapy for Psychosis program. And do you see my slides? You do. Good. Okay. And so I created this presentation in part because originally, when I was a therapist on a first team, which serves clients experiencing their first episode of psychosis, I really wanted to try my best to do my best work. And now, as a consultant, I provide consultation to first teams around the state of Ohio. And I've been thinking a lot about how to help them be effective in their practice as well. And so I want to start with a question. How long does knowledge about psychology stay current? Feel free to type your answers in the chat, or this is a small enough group. If you want to venture a guess, feel free to just tell me what you think. Any courageous guessers?
I think that might depend on how you define current to a large degree.
That's fair, Nicole. How would you define current?
Probably a bit more shorter of a time period than I think the standards are for what we consider current practice in the world of mental health, but I do have a biased answer there, I think. So I'd like to hear from other folks, maybe our students. How long do you think it stays current?
I don't think long. I don't have really a good answer. I don't know. Just, I feel like it changes quite a bit.
That's fair. There is a lot of change, right? So it's kind of hard to pin down an exact time frame if you're just kind of thinking about it. I'll give you guys a few more seconds to think about your answer, but while we're thinking about this question, I'd just like to invite you to think about how an intrinsic part of being a helping professional is our responsibility to learn a body of knowledge about people, how to understand and work with their thoughts, their emotions, their behavior. This is more geared toward therapists. Your emphasis might be slightly different. But whatever your body of knowledge is, we try to use this knowledge in our work to help people change. But learning isn't static. And I'd like to invite you to think about where you're at in the process of learning as we talk about this today. So, drum roll, here's my answer, or the answer that the research shows. So, oh, is it going? There we go. 6 to 7 years is what the research says for remaining current. But in some specialties, it's as little as 3 to 4 years. Did that match up, Nicole, with kind of your impressions, or were you thinking even shorter than that?
Oh, I was kind of assuming that we think of current as being much longer than that, but it probably should be much shorter than that.
Okay. So if you work in a helping profession for 25 years, this means that you would have to refresh your body of knowledge about 3 to 4 times over the course of your career. So staying current in any field is really challenging, and learning anything involves a commitment of time and energy. But it's important for people who work in these professions to take that commitment seriously because the quality of your work depends on it. Now, there's multiple ways that therapists and other types of practitioners learn. And so a useful analogy is to think of your learning experience as being a stool with 3 legs. And each leg represents one source of knowledge that's derived in some specific way. The legs of the stool are academic research or theory, a practitioner's experiences working with people, and one's own personal experiences or lived experiences. And these legs roughly map onto a model of therapist skill development called the DPR model. And the DPR model describes 3 systems by which therapists in particular learn their craft: declarative, procedural, and reflective systems. But the important thing for you to know is that there are 3 legs. And to be balanced, it helps to pay attention to all 3 aspects of your learning and to kind of ask yourself which is stronger and which is weaker for you. And so learning is a process that evolves over one's career. And in the early stages of a practitioner's career, there's more emphasis on acquiring knowledge and on learning when and how to apply that knowledge. But gaining knowledge alone is not sufficient for becoming a better practitioner. What you can learn can become inert or inactive if you don't actually use it out in the real world. Experienced therapists have knowledge about how to apply what they've learned. It's just the type of knowledge that people learn from quote unquote just doing it. But what really distinguishes expert practitioners is the reflective component of learning. Self-reflection involves observing and evaluating yourself, being aware of your strengths, your limitations, your biases. That's all part of self-reflection. And so it's this reflective component of learning that usually takes on a larger role later on in a person's career. But regardless of which stage you're at in your career, all of these components are important to think about as you develop your skills. And it helps to think of learning as a continuous process that integrates all of these systems. The experiential learning cycle that you see here is one way that these components are integrated. It shows how you might move from introducing a concrete task to reflectively observing on the results of that task, to conceptualizing what you learned, and then actively experimenting with a strategy based on what you've learned. So these are the building blocks of the learning process. So I'll give you an example here. So if a therapist is working with somebody who's exhibiting paranoia about being followed, that therapist might first try to explore evidence for that person's paranoid beliefs. But then after reflecting on the encounter, that person might realize that the therapist was trying too hard to persuade the client that his paranoia was not correct, rather than allowing good Socratic questioning to lead him to a similar conclusion on his own. And so in response, that therapist might take this reflective observation back to his supervisor and practice a different way of approaching paranoid thinking using the principles of guided discovery rather than persuasion. And then through this practice, that therapist might come to understand that he needs to use more empathic listening and he needs to increase his use of summaries and reflections in his sessions. And then he might develop ways to do that at his next appointment. And so as a person's faced with this task of deciding where to focus their energy. Like, what do you want to learn or what should you learn? There's a plethora of things to learn, a lot of therapeutic approaches, and it's impossible to know or learn everything there is to know. And so one way to focus or direct your attention is to focus it on approaches that are evidence-based and which have direct applicability to the population you serve. And once you identify a model, you can learn it inside and out. And so for those of us like me who work in the psychosis space, cognitive behavioral therapy for psychosis is a natural fit. It's an approach that's evidence-based, but it does take time and practice to do well. Knowing and adhering to the core components of a psychotherapy model like CBTP is important, but psychotherapy is inherently human. There's also the art of how you apply it. And I'm going to use an analogy here. So think about cooking, right? If you're preparing a certain dish, there's a recipe for making that dish. The recipe outlines the ingredients you need to use, but not all of the ingredients have the same value. Some ingredients are essential to the dish, while others can be used more flexibly. So chocolate chip cookie is not a chocolate chip cookie without chocolate chips, right? So in the same way, CBTP is a model that has key ingredients, but it also has other ingredients that you can play around with. And for CBTP therapists, one objective is to learn the core components of CBTP and to apply them with fidelity while allowing some room for some creativity and some flexibility with those components that aren't core to the model. And so if you don't practice CBTP, I'd encourage you to think about how you practice and what the core components of your model is. So what are the core components of CBTP? Well, the list on the left are the competencies measured by the cognitive therapy scale. That's the scale that Aaron Beck and his associates developed. That's the most widely used general measure of therapist adherence and competence in CBT. On the right is a list of CBTP specific competencies. And so you'll notice those standards require that a therapist be competent in the general CBT model first, but then they add competencies that are related to psychosis. For example, there's an emphasis on adopting a recovery orientation during engagement, using normalizing to reduce stigma, understanding cognitive formulations for things like hallucinations, paranoia, delusions, that sort of thing. And so a CBTP clinician who's adhering to the model needs to be familiar with these competencies to use it effectively. But a lot of clinicians discover that learning CBT, it can present some challenges. It's normal to encounter barriers. We're all imperfect. We all make mistakes. We all have bad days, right? But more importantly, knowing common barriers that lots of people encounter can help you become aware of them. So I'd encourage you to think about this list. If you're a therapist, if you're not a therapist, think about whatever your list might look like. I'll give you a point of disclosure for me. Like I struggle sometimes to incorporate homework assignments into my sessions, which is a core CBT skill. And so I've been trying to address that in my sessions with clients that I work with. And then learning CBTP involves more than just learning the generic model. So as I mentioned, there's a lot of models of psychosis symptoms, and they can be theoretically complex. When researchers in academic settings develop these models to try to explain things, they try to be as comprehensive as possible. Academic settings often emphasize rigorous analysis over practical utility or realistic application. And this can make learning models of psychosis feel overwhelming for people, especially if you work in a community-based setting or a hospital setting. But many trainees in CBTP want to develop simpler formulations with their clients. It helps their learning to do it that way as well as the client's learning. And this is where that flexibility can come in handy, right? You can simplify things enough that they can be understood easily and applied, but you don't want to oversimplify to the point where you lose those core components. It's a tricky balancing act, but it's a balancing act that we all face using research to inform practice. And so in practical terms, how can we improve our clinical skills? Well, the first thing I encourage is for you to become an active participant in the learning process. Therapists I know like to often get very specific answers to their questions from supervisors and consultants. But one thing we know is that true growth comes when you wrestle with difficult problems and actively generate your own solutions with your own thinking and reasoning. And then supervision and consultation can be a great way to clarify your thinking and get support in enhancing your skills. But the growth starts with you. To get the most out of supervision and consultation, it can be helpful to think about a specific question to ask or an issue to discuss. And this can be challenging for lots of reasons. There can be some real vulnerability when you seek out feedback and admit that you don't know what to do, but that's part of what we do, right? Embracing vulnerability so that you can uncover your gaps and improve. And it can also just be helpful to review common barriers to learning CBT, like we mentioned earlier, and to seek out opportunities to actively learn through role plays, live observations, and fidelity reviews. I'll say here that when I was learning another model of therapy, a form of family therapy, I had an opportunity to have a consultant in that approach observe me live. It was one of the most valuable things that I've ever done because she was able to watch me actually apply the skills in real time and then give me real time feedback. So if you have that opportunity, definitely use it. And then I'll say here, in the spirit of the integrated care echo, I think consultation is just also a great way to get other people's perspectives and to understand how other people work from their point of view with their discipline in mind. So I often like that part of it too, just kind of learning from a perspective I'm not familiar with. I'll show you this here. In other audiences, I really promote this. This is the skill development pathway that the CBTP program is developing to try to help therapists and case managers and other frontline providers learn CBTP skills and use them. If you want to learn more, feel free to reach out to me. But I'm going to end with a few reflection questions, some of which you saw at the beginning. I want you to think about, so which legs of the stool are strongest for you? Which do you need to reinforce? What's your plan for improving your skills? And then again, in the spirit of integrated care, how can you learn aspects of practice from other disciplines that you encounter, work with? Are there any questions?
Yes, I have a question.